everybody, and welcome to today's podcast in relation to the Modern Ward Round collaborative that we're currently running with RCP and RCN. Today I'm joined by Dr Gordon Caldwell, who most of you will have met on some of the Modern Ward Round collaborative events so far. My name's Claire Sanders. I'm an improvement manager with ECIST.
Yeah, I'm Dr Gordon Caldwell. I'm a consultant physician. Currently I work up in Oban Hospital on the northwest coast of Scotland. But previously I worked down in Sussex at Worthing Hospital. I qualified back in 1980 and I was a consultant from 1993. Thank you.
Thanks, Gordon. I'm just going to kick off with a question first off. We know that you've written extensively about ward rounds and you're well known for the ward round checklist. I'd really like to find out more about what guided you to start this work. What prompted you to look at ward rounds in particular?
I think what started me off would have been recognising harms that came to patients through processes that weren't tight enough on our ward rounds. I think I can particularly remember a patient who had successfully treated for pneumonia on the background of COPD. And a few days before his intravenous antibiotics had finished and he was getting ready for going home, and he asked what was the problem with his left arm. And when I looked at his left arm, he had very red inflamed cellulitis with tracking up into his armpit, which was a secondary infection from the cannula site. And it turned out to be an MRSA infection. And his cannula had been left in for 3 days when it should have been taken out. And it just struck me that if we had a standard process for the ward round, including safety checking, we could have averted that. So I think that initially it was coming from patients or other patients who had anaphylactic reactions to intravenous antibiotics they were known to be allergic to. So obviously our signalling there was inadequate. So I'm sure the initial motivation was patient harms and trying to establish some standard process to make sure that we avoided patient harms. The other reason I was interested in ward rounds is because it's difficult to study a lot of things in medicine because people are generally interested in rare and unusual things, whereas ward rounds are very common. So if I was looking for quality improvement projects for my junior doctors to be involved in, there wasn't ever going to be any difficulty in finding enough matters of interest in ward rounds because they're happening all the time. Further than that, I think it's difficult to imagine an acute hospital without a ward round. It's almost a definition of what an acute hospital is. It's a place where ward rounds happen. And our patients come in acutely ill. We anticipate, we hope obviously that they're going to get better. There's always things happening that knock patients off course one way or another. So a ward round is a chance to review a patient's progress, to see whether they're progressing towards trajectory, whether they're deteriorating. If they are deteriorating, what's gone wrong, revising the plans, making new plans to move ahead until the next time for review. So they're an essential component of hospital life, but seem not to have been studied in any way. I was counted for how many outpatients I did, what my waiting times were in outpatients, my reattendance rates, but nobody seemed interested in what time my ward rounds started, how long they took, what was happening, what the outputs were. So we got this vast investment in ward rounds throughout the NHS, millions of pounds each day spent on ward rounds and the consequences of ward rounds, but strangely, the leaders in the organisations not interested in the ergonomics of the ward rounds. So I was, again, convinced there were things that we could do which would improve effectiveness, efficiency, safety, productivity, patient satisfaction, and hopefully just our enjoyment of our work. Thank you.
Thank you, Gordon. I suppose that resulted in the development of the checklist, the ward round checklist that you worked on.
Yes, with the checklist, I'd already been interested in ward rounds by the time we came around to thinking about the checklist. And I'd been interested in training my junior doctors in how to lead ward rounds. Obviously, the registrars are going to become consultants. So how could I train them to become consultants capable of doing ward rounds? So I used to let the registrars do the ward rounds. And then the more junior doctors wanted to have a go as well, what we used to call the senior house officers. And then one day, year one doctor, foundation year Dr. Claire, did the ward round, 27 patients, I think she saw, under the supervision of myself and the registrars. And at the end, we asked her how it had gone. And she said, that was great, you were supportive and helpful, and it felt good. But I didn't know if I'd done everything. And that was a Monday. So I don't think anybody's ever thought what doing everything is for the patient on a ward round. So why don't you come back on Wednesday and we'll contribute our ideas as to what doing it all is on a ward round. And on the Friday, we had our first checklist, which started with things like, have you organised the notes in the folder? Are they legible? Have you written down a diagnosis? And then I think that's where we started this idea of active patient safety checking, rather than just going through, oh, you've got pneumonia, your temperature's down, your white cell count's better, good, you'll be going home in a day or two. Could we put in some active patient safety checking? Is the patient eating and drinking? Are they walking? Have they got a catheter, a cannula? Are they falls risk, pressure risk? Have we looked at all the results and such like? And in those days, I had more staff on my ward round, so I could allocate a role of being the checker, which we often did to the medical students, and told them they had to tell us the stuff we'd missed out. And in that way, it could be very objective. They say, Dr. Caldwell, I don't remember seeing you look for a cannula in the patient's arm, and then pull the sleeves up and find they've got 3 cannulas in and take them out. So the checklist came really from us thinking what is going on in a ward round, which is very complex, and how can we make sure that all the important issues have been addressed? So we're not telling people what they've got to do, other than they've got to decide whether the patient has VT prophylaxis or not. I'm not telling them they've got to have it or not have it, but you've got to have made an active decision one way or the other. So that was really much the genesis of the ward round checklist.
Thank you. So could you tell us a little bit more about the 2 things that we know you best for? And I think those 2 things are the need for organisation, but also connection with the person. So I'd like to know a little bit more about that, please.
Yeah. So I can't think of any human activity or valuable human activity that's better if it's unorganised or disorganised. And yet I was aware from my own training, observing other consultants leading ward rounds and participating in ward rounds, that there was no standard sort of process to it. And there was even one consultant who asked, how did he organise his ward rounds? He said he thought he did it differently every day. Well, if you've got new staff coming in all the time, like we have with rotas in the NHS now, nobody could possibly prepare the ward round for him if he was doing it a different way every day. So I think organisation is essential to safety and effectiveness. And most of the time during my work on ward rounds, it's been very simple tools I've developed to organise the ward round. When I was in Worthing Hospital, just before I left there for the last year or so, we had a very simple sheet which listed the names of the staff who are on the ward round, what their roles were, how many new patients there were, how many review patients, anybody who was critically ill, anybody who we thought might die in the next 24 hours. And then a list of the patients with the checklist there, and went through the checklist on each patient. So very simple, one side of A4 that put some organisation and structure into the ward round. And Osler, back in the 19th century, said that physicians undervalue organisation compared with almost all other professionals. And it's difficult because each patient is different, they're very complex. So you could say, well, how can you have organisation? But if it comes to who's on the team, what are their roles, what are you going to do if an emergency arises, how much work is there to do, I think that sort of organisation is essential, and it helps the team to know what's going to happen next. When I'm doing a ward round in Oban, the nurses know what question I'm going to ask next, so they're ready with the answer. So organisation, I think, is absolutely essential. And then the connection with the patient. Personally, for me, the practice of medicine has always been the professional, personal relationship with a person. And again, unfortunately, I think because of the target-driven nature of the NHS now, people have just become regarded as diagnoses who are moving through a pathway to an outcome. And that takes away the personalisation, takes away person-centred care, shared decision-making, but also just the ordinary connection that human beings expect. If I meet somebody on the bus and talk to them, I'll ask them, where are they from? What's their job? What are they interested in? And I think so. I ask those sort of questions unless the patient's unconscious or in absolute need of urgent treatment. How old are you? An easy question for somebody to answer to get them talking. What is or was your job? What are your current interests? What do you enjoy currently in your life? And then I use that information in the handovers or in the introduction of the patient, maybe to another consultant. I want you to see this 75-year-old retired primary school teacher who's still got sheep and cattle, who's got an acute nephritis. Can you help me with their management? And that connection, I think, helps to make the care personalized. It engenders trust from the patients. They're going to divulge more information towards the diagnosis, makes the clinicians, the doctors, the nurses, all the healthcare professionals feel more responsible for the patient, and interested in the good outcomes. And apart from that as well, it makes work interesting and enjoyable because there's something else on ward rounds to talk about other than just the medicine all the time.
Fantastic.
So I think that connection is something that I can remember. We had a surgeon came down, and I was sure he was going to go away with the idea that he'd use a checklist because surgeons are very methodical and want to use checklists. And he said he was going to go back to his ward the next day and make sure that something personal was recorded about every patient on his ward.
Brilliant.
Thank you.
Moving on then, what do you think are the barriers to improving ward rounds? What's stopping others from adopting different ways of working?
Yeah, that's always seemed a big challenge to me, that is how to get people interested in this process, and what's stopping the leaders in hospitals from addressing the issue. They'll have quality improvement projects on utilising theatre time or flow out of A&E to the wards, but this basic productive function in the hospital has been unstudied, and I don't know why it should have been unstudied. I think one thing they might think, oh, doctors are very smart people, therefore they've got it all sorted out, would be one problem, one possible explanation. Another, I think, is that people just don't see that it's poorly organised and dangerous and risky and could be so much better. Often using an analogy, maybe if you're in India, in a big city and there's a huge roundabout and there's lots of accidents and crowding and difficulty, the people in India actually think that's ordinary. And then you've got this big, how would you get them to see that you could have it much safer? How would you change all the culture of driving and learning and make all the changes to make that area safe? So I think just because within a few months of entering into the NHS, people just accept as ordinary what is ordinary, and don't see that there needs to be a whole lot of change. And one of the things I think, having invited people from outside the NHS into the NHS, is they actually can't believe how poor the systems are. I can see a patient on a ward round and request a CT scan of great importance to the diagnosis or management of the patient, but I actually don't know whether somebody's filled in the form, whether the form's gone to X-ray, whether they've set an appointment, whether the patient's attended, whether the test has been done, whether the result's been issued, and whether the results come back to me. All that runs on crossing your fingers. So I think there's this is the way it is, therefore there can't be anything wrong with it. I think must be one of the problems here. Yeah. And also, I mean, it's all basic organisation of the team, organisation of this bits of kit you've got. We're very expensive resources, but we're not doing something new and sexy like a new cardiac intervention. It's, in that sense, it's pretty low, in one sense, low tech stuff, but it's absolutely vital. Mm-hmm. So there's lots of reasons why I think it's difficult to engage people in trying to change it. And most of us who've tried to change things in the NHS know you need endless perseverance and enthusiasm. try and make things happen, and be willing to accept that after years of work, you may have made very little progress.
Yeah, but I'm sure you're right. I think it's about customer practice, but the fact it's medical customer practice as well probably makes it doubly hard, doesn't it, to kind of break through and challenge what's accepted in the norm. Mm-hmm. Yeah, it's really interesting. Okay, moving on then, what would you say are your top tips for delivering improvement to ward rounds?
My top tips. Well, I think the first one I would go back to is that connection with the patient. If there's one thing you're going to do is to, in a sense, label the way other than just their age and sex and diagnosis. Something that, in agreement with the patient, this is how I want to be remembered, because that creates that connection. And I think if you've got the connection there, that's going to drive the interest in the correct diagnosis, the correct treatment, the safety, the quality, the engagement with the patient. I don't know why there's been so much depersonalization. I think part of it may be because the systems have become unsatisfactory and shoddy, and people, if you identify with the patient that much, you're going to feel the pain sometimes that the patient's experiencing in these systems. But I think that would be my top tip, would be remember that medicine is a human practice, professional and personal human practice, and make that connection. Some people say that there isn't time for that. Well, I found it's rare for that conversation to exceed 60 seconds of tell me your age, what was or is your occupation, what's your interest, what do you enjoy now, and then to make a note of that and hold it. And for me, it's often the occupation. Another consultant always asked people what their favourite piece of music was, and he remembered them by their favourite piece of music.
Yeah.
But something to make it personal. Do something to get organised. I think when I was starting to do the checklist work, I'd read Atul Gawande's books, and in his book Better, he pretty much finished by saying, "Stop moaning, do something, and count." So I can remember that I decided I'd count my ward rounds, and instead of just moaning the nurse was never at the bedside, I'd count how often the nurse was at the bedside. So doing something very simple that's easy to do. When did the ward round start? When did it finish? How many new patients? How many review patients? Was there a nurse at the bedside? If there wasn't a nurse at the bedside, did you go and find one and speak to them? So very, very simple, achievable things. And I think on the active safety checking, I'm aware still that my safety checklist is too long. I think if, as a team, you could decide that you're going to check one, maybe two aspects of patient care on every ward round, every patient. So I think a good one is the patient being prescribed an antibiotic? That's a very good question, because it means somebody's got to pick up the drug chart and look at it. And when they look for the antibiotic, they might spot a whole lot of other errors. Other information on things that need correcting on the drug chart. Yeah, and has the patient got a cannula or a catheter? And then you go through and you check on that. And I think what I was able to do early on with somebody being assigned the checker gives that person the authority to say, no, that hasn't been checked, even if it's a consultant or the senior registrar. Simple fact, no, it hasn't been checked. We must check it. That sets the culture within the team that you know there's going to be errors, that it's all right to speak out about the error, as long as you get the error corrected. So start with very simple, achievable things, and some counting. And the counting, apart from anything else, changes moans into statistics. And managers can understand statistics, but they can brush aside people who moan.
Gordon, is there anything that you think we've missed that you'd like to add in?
There's the enjoyable challenge of trying to show that everything that you've done has made a difference. Because even now, after all these years of work, it's very, very difficult to prove that anything's made any difference. But that comes down, I think, to my answer to that was when the hospital is in a real mess and it's busy and it's heaving at the seams, the chief executive always asks people to go and do ward rounds. So the chief executive at least believes the ward round's an essential and important activity. Yeah. So if it's essential and important, it can only be better if we do it more effectively, more efficiently, more safely. So if I've done something which has proven that I've made the process more thorough and quicker and happier, then that must be of value, whether it reduces the length of stay or not.
That would be a good thing.
Yeah. On the organisation, I think I had a comment that when I started thinking about improving ward rounds back in 2004, at that stage I was doing a lot of after admitting ward rounds, so-called post-take ward rounds. And I just had a dream of what the ward round would be like, an ideal busy ward round. It couldn't be a quiet ward round, it had to be an ideal ward round, and I had this picture that come in the morning, and the junior doctors who had been on the night shift would know exactly how many patients there were, where they all were in the ward. The notes would be laid out on the table in line, either by hospital number or by bed number. There'd be a place marker in the middle of them. The notes would be legible. They'd talk succinctly and shortly about the patient to brief me before we got to the patient. When we got to the bedside, the patient would be there, the nurse would be there, the vital signs would be available, the drug chart would be available. We could communicate freely at the end of the ward round, would sum up and we'd allocate tasks. And that really just Dream ward round emphasised the importance of organisation, training, efficiency, safety, productivity. And that was so far away from how the ward round was. But some of that I'd never expressed to people before. That I just wanted all the notes in line and a place marker. Good, okay, we've got that sorted. Now what do we do next? Yeah. So that idea of having a dream of how you'd like things to be. And earlier today we had the workshop on the structured interdisciplinary bedside rounds. And I'd love to be able to do that, to take the multidisciplinary team to the patient's bedside and involve the patient and get all the work done in 3 or 4 minutes. It'd be wonderful. So always having a dream and a vision and trying to sell that dream and vision and trying to make little changes moving towards it. And each person's solution might be different. So that was a bit about organisation. The connection.
Do you think of those areas that are trialling out ward rounds away from the bedside? Nick and I have just been reading about those. What are your views on that at the moment?
How do you mean taking it away?
So the ward round not happening as in rounding the ward, but actually the MDT is sat in a room and the patient comes to the MDT.
Oh, right.
So just switching it around.
Right. Yeah. No, I think that's an alternative solution, and I've seen that happen. Valdemar Erling in Gothenburg, just north of Gothenburg, he set up ward round rooms on that basis. So the model is perhaps more like a psychiatry ward round, where the patients come in and the whole team's there with the patient. And his vision was to get away from the interruption, the distraction, the noise. That the night nursing team would decide which patients would come to the ward round room for their consultation. And that of itself encourages mobilization, because a lot of patients would say, oh, I'm going to get up and I'm going to show them I can walk down to the room. But within the room itself, then that firstly you need much less IT kit, because you've just got 3 rooms rather than 21 beds or whatever it is. And the consultations that I saw there, even though they're conducted in Swedish, were obviously very different level of conversation and interaction between the patient and the clinical team. It was a much more adult conversation, a much more shared conversation, and more driven by the patient. So I think that's an alternative solution to the difficulties we have with rounds. And on that round that I did with Valdemar, I think about 25% of the patients weren't well enough to come to the room. And then you could immediately feel the inferiority of the bedside review in that context. But I think with the cyber round, that gets around some of that problem. It's just a different solution of how do you get the multidisciplinary team talking consistently about the patient. Sometimes I thought you meant about, the whole ward round happens without the patient, which I've seen happen well. But I think in the MDT meetings I'm at, sometimes we're talking about different patients even. We think we're talking about Mrs. McTavish, but the occupational therapist is talking about Mrs. McKenzie. So then we get really tied up, whereas if at least the patients in front of you are all agreed that this is
the same patient.
The right patient, assuming it's the right patient in the right bed, but at least you're talking about the same thing.
So thank you very much, Gordon. That's been really insightful and really helpful. I think the key messages really are around keeping it simple, being organised, and having that real connection with the person. So been really great talking to you. Thank you so much.
Okay. And thank you too, Claire, and for the support that I've had from ECIST, which has been wonderful to see the ideas I had many years ago beginning to bear fruit around the country. It's wonderful. Thank you.
Thank you.